Good evening, everyone. Welcome. Happy Thursday. Thank you for joining us for this virtual UMiami Health Talk, Advances in Joint Pain Management and Replacement Surgery. I'm health journalist Julianne Bravo, your moderator for tonight's talk, presented by UHealth Virtual Clinics. Now, UHealth's expert providers are ready to care for you in our facilities or virtually, wherever you are. And we invite you to learn more about the strict measures we have in place to keep you safe, as well as your appointment scheduling options by visiting umiamihealth.org. Tonight, we're pleased to hear from University of Miami Health System orthopedic experts, Dr. Julianne Muñoz, speaking on shoulder joint pain and replacement, and Dr. Jaime Carvajal, speaking on the conservative management of joint pain and on the innovative treatment options on the horizon and those available now for implant surgery. Our third expert, Dr. Mikhail Diapuzzo, is unable to join us as planned due to unforeseen circumstances and sends his regrets. Okay, so let's get ready and let's tell you about the format. We're going to have a question and answer session at the end of the presentation to answer as many questions of yours as we can get. Now, if you didn't submit one in advance, you can still ask them by using the anonymous Q&A feature at the bottom of your Zoom screen. You can do it throughout, and we'll prepare them for our panelists at the end of the presentation. So I'm pleased to introduce our first presenter, Dr. Julianne Muñoz, an orthopedic surgeon and sports medicine physician at the University of Miami Sports Medicine Institute and an assistant professor of orthopedic surgery and sports medicine in the Miller School of Medicine, Department of Orthopedics. Her clinical focus is orthopedic surgery for the shoulder, elbow, and sports medicine injuries. In addition to her surgical practice, Dr. Muñoz is a member of the medical team for the University of Miami sports teams and the Miami Marlins. Let's welcome Dr. Muñoz. Take it away.
Thank you so much, Ileana, and thank you to everybody for participating tonight and giving us an hour of your time on what I'm sure is a busy Thursday for everybody. Like Ileana said, my name is Julianne Muñoz, and I'm excited to talk to you a little bit more about shoulder pain and total shoulder replacement, which is typically one of the lesser talked about or one of the lesser known possibilities in joint replacement. I think people focus a lot on the hip and knee because those injuries tend to be more common, but we have a lot of wonderful technology for painful shoulders as well. So I'd like to just make sure that everybody understands what a total shoulder replacement can actually treat, because there are many injuries about the shoulder that are not treated with a shoulder replacement. And really they have to be bony or joint in nature. So things like arthritis, humerus fractures, revision surgery, or massive chronic rotator cuff tears that at a certain point become an arthritic process can be treated with shoulder replacements. Some of the soft tissue injuries that I'm sure people hear a lot about, like rotator cuff tearing or labral injuries, those are not really amenable to joint replacement. And there are other sports medicine soft tissue type procedures that are more appropriate for those injuries. So if you've been diagnosed with a bony problem, an arthritic problem, a terrible fracture that needs to be reconstructed with an implant, these are all things that are amenable to shoulder replacement. If you've started looking into this for yourself, you pretty quickly have found that there's two different types of shoulder replacements, and this can cause a lot of confusion for people. If you look at the X-ray imaging there, and then the diagrams below, you'll see that in a normal shoulder, it's a ball and socket joint, where the ball is on the long bone of the humerus, and the socket's actually part of your scapula. So in a normal anatomic or standard total shoulder replacement, we're just replacing the joint that nature gave you with a metal and plastic component, but we're not changing the arrangement of your joint at all. There is really only one indication for that, and it's good old-fashioned arthritis, because that type of implant replaces arthritic surfaces, and you can still use your rotator cuff tendons to move and power the implant like you would your own shoulder. But for all of the other types of problems that we see, people that have no more rotator cuff left, they still have arthritis there, or if they have such severe bone loss that you can no longer implant a normal type of total shoulder replacement, that's when we turn to the reverse style. And you'll see in those diagrams and in the final image that we've reversed or we've flipped the anatomy as nature intended. So the ball is now on the scapula side and the socket is on the humeral side. So it's really quite literal. It's just reversing your anatomy, and that's why we call it a reverse. So for any of these conditions, really any orthopedic condition in general, with the exception of some, traumatic type things that are chronic and overuse and have developed over time, really are worthy of a conservative effort. And the first line of conservative treatment when we talk about medications are typically anti-inflammatories. For most patients, these are safe, but for people that have severe stomach problems, severe ulcer problems, or have trouble with kidney function, we sometimes have to amend those plans because they can have some side effects for patients in that category. In addition to this, physical therapy in the shoulder particularly is hugely helpful because there's no joint that has as much range of motion in the body as the shoulder. So once people start becoming painful, they really begin to develop compensatory movement that then can also be painful. So the only way to correct that is with the help of a physical therapist. So usually for a patient that doesn't have end-stage arthritis yet, but is starting to have some painful symptoms and some uncoordinated movements with the shoulder, I'll start with a good plan for anti-inflammatories and a good physical therapy regimen. You can then move to the next line of treatment, which includes a multitude of different injectable options. There are many on the market now, and they all have a pro and con profile that come with them. But they are an excellent option for people that are still in sort of the moderate, not end stage phase of arthritis. In addition to kind of all of these things, sometimes it requires a discussion about what the patient is actually doing in terms of profession or recreation, the intensity of their activities, and whether anything can be easily modified to help decrease the burden on whichever joint is ailing you. So for shoulder replacement, people often ask me, well, what's this going to do for me? What am I going to get out of this? It's best done when patients have both pain and range of motion problems. And typically when you start having arthritic or chronic rotator cuff arthritic disease in the shoulder, patients usually lose their overhead motion first, and overhead meaning raising your arm above your head. So when you have that combination of pain and no longer able to range your shoulder, that means you're in a category of people that is going to get the most out of what a shoulder replacement could give somebody. When you still have perfect range of motion and you're just having pain, you just don't have as much to gain from this type of surgery. So that's why it still makes sense to see if there are other options that can help treat pain when range of motion isn't an issue yet for you. When you are in that category of people that really has both of those big chief complaints, as we call them in medicine, the total shoulder replacement can give you back wonderful ranges of activities that my patients tell me they've lost. They can't dress themselves. A common complaint in women when they're trying to put their hands behind their backs to put on a bra, or men trying to put a belt around their backs, reaching up to get things out of the cabinet, picking up grandchildren and feeling like you have a steady pair of arms to do so. Those are all things that my patients tell me, oh, we did the joint replacement and now I'm doing all of that stuff much easier. Or I stopped doing it before. I had to create little hacks for myself to get through my day, and now I don't need to use those things. In addition, a total shoulder replacement can get people back to a wide range of recreational activities as well. It's certainly reasonable to get back to golfing, tennis, recreational kind of backyard style sports. I use backyard, meaning it's not great to expect that you're going to be pitching or back on the football field. That's not a realistic expectation. But certainly golf, tennis, I usually do tell people that you may see your handicap change a little bit. You may see your serve technique change a little bit, but you can most certainly get back out there and continue enjoying things that you may have stopped doing for a few years at that point. So what won't a shoulder replacement achieve? So a shoulder replacement, it's important to understand that it is an artificial joint. It's metal and plastic. It is not what nature gave you. So it will not make you feel like you did when you were 30. It will help with pain. It will help with range of motion. But there are still times where people have some aches and pains. A very common complaint that we don't have a great scientific explanation for is on a rainy day or cold days, people tend to get a little achiness from time to time. And that's because it's not perfection. There are times where people don't have an arthritic joint, but they still get aches and pains from time to time. And that's kind of the realistic expectation that you should have after a joint replacement. I have some patients that are still employed in very, very aggressive jobs. I have a lot of construction workers. I have a lot of patients in law enforcement that are very aggressive in what they do from day to day. And it's not appropriate for that type of activity because they can wear out, they can loosen, and they can fall out, which then requires multiple revision surgeries. And generally, if we can keep revision surgeries to a minimum, that's the best way to plan for your joint replacement course as you move forward for the rest of your life. A little bit dependent on the age that you have your first joint replacement, which brings me to the next point. If you are very young, if you are under 60 years old and you haven't tried other conservative measures, those should always be tried first. And if it is appropriate to discuss joint replacement in a young patient, then it's just very important that both the surgeon and the patient have very, very clear expectations of what sorts of activities the patient will be back to and the longevity of the implant when you're getting one so young. And then as always, anytime you sit with a surgeon, there will always be a discussion about the risks, the benefits, the fact that there is no one fits all outcome. And whether for you personally, it seems like the joint replacement is the best option at that point in time for you. And so that's obviously a very personal conversation between surgeon and specific patient. So you're sitting with your surgeon, you both agree that the x-rays show end-stage disease and your physical exam and what you're explaining to your surgeon at home all fit the bill for you being a wonderful joint replacement candidate. So just, some things to have a heads up about that will be discussed at that visit. Certainly your overall health status. These are generally procedures that are done under general anesthesia. So that's why it's pertinent for us what your cardiac history is. Certainly diabetes and smoking, we know for a fact, raises your infection rates after these type of surgeries. And infection and total joint replacement is no joke. It is a very difficult thing to treat, and it is even more difficult thing for a patient to live through. So that is why we ask you about your diabetic control. It's why we ask you if you're smoking, because we want to work with you to help optimize those preoperative risk factors so that you can get the best result possible. The same thing with weight control. If your weight control is optimized, these implants will function at their best. So that's the reason why you will, talk about those things when you are sitting down in your preoperative appointment. Some of the wonderful things that have happened more recently are that we do these joint replacements either same day ambulatory surgery or just with a one-night hospital stay. And that's pretty dependent on your health history and the hospital policy and sometimes your insurance policies as well. But we work through all of that with you so that you know what to expect beforehand. Surgeons are a little bit different in their postoperative protocols, but I'm giving you mine right here. So for me, joint replacements end up in a sling for 4 weeks, which is usually the toughest time because you feel a little bit trapped. But after that, you come out of the sling, you can move your arm however you like. You just cannot lift anything for about 3 months postoperatively. Once you've come out of that sling, you'll start with a very regimented physical therapy program that usually lasts for about 3 to 4 months. Patients usually go to therapy 2 to 3 times a week. You can pick your therapy office, and any of your surgeons always have a list of wonderful recommendations of offices that they know are familiar with their style of practice. Another great question is time off work. This is very dependent on what type of work you do, but in general, if it's desk work, people can be back after about 2 weeks. I usually tell people, give yourself 2 weeks just to make sure that you can get your pain nicely controlled. Most of my patients are off pain medication other than anti-inflammatory medicines by the 2-week mark, and they're ready to go back to work with the understanding that they'll be in a sling for a short period of time longer. If you have an active job, then you need to prepare your boss for the fact that you'll be light duty at least until 3 months. And then even at that 3-month mark, you still won't be fully strengthened, but you'll be allowed to do, some gradual heavier lifting at your job. And then most of the time, somewhere between the 4 and 6 month mark, patients are feeling like they're fully recovered and where they want to be when they first made the decision that they wanted the joint replacement. In my practice, I do like to see patients once a year afterwards to get x-rays to make sure that we're not seeing any loosening or movement of the implants. But that's usually a very quick visit where we're getting x-rays, saying hello, catching up, and then we see you the following year. And then this is just a slide about the more immediate postoperative period, because I get a lot of questions about that in our preoperative discussion. So I mentioned, that there are much quicker hospital stays for these surgeries now. The other thing that has advanced greatly over the past 10 years is pain control. So all of the anesthesiologists that we work for these procedures are experts in regional anesthesia, which means that nerve blocks that can help you with pain control over the course of anywhere from 16 to 48 hours, depending on what type of blocks or catheters they've decided to use. You can expect to go home on a combination of pain medications to help maximize your pain relief, but to help minimize some of the ugly side effects that some of these different medications can cause. So in my practice, I use a very good, effective, strong anti-inflammatory medication for a few days after surgery, a very short course of a narcotic medication, and then anti-constipation medications, because unfortunately, that is one of the nasty side effects of all narcotics. And like I said before, it is very rare that at the 2-week visit, I have patients that are requiring any more narcotic. And most people tell me that they actually only took it for a few days and they're asking me how to get rid of it, which is appropriate for obvious reasons. My patients go home with a type of dressing that you can shower with. So really the next day you can get into the shower with a helping hand and just let the water roll off with the dressing. You're sent home with this ice machine that you can see pictured here, which really helps with swelling and pain control over the course of the week or two after surgery. Most of the time patients are able to drive sometime between the 6 and 8 week mark, but a lot of that depends on your confidence and your pain control. So it's a little bit individualized patient to patient. But one fantastic rule of thumb is that you never really know exactly how you're going to react to these surgeries. And not every patient is the same. So it's not something that you want to go through without a friend or a family member. So if it's something that you are planning, it is most definitely something you should tell your family that you're planning, particularly if you live alone, because it is the time where a sister, a brother, an adult child should come and pay a visit for a week or two if they can. It's always better if you find you didn't need the help than if you are really struggling to, put dinner on the table or to get yourself bathed in the first couple of days after surgery. And so finally, I have a lot of patients also asking me, what's different about total shoulder replacement now than it was, 10, 15 years ago when you were training? And there's a lot. Every year there is some new gadget, gizmo, technique that comes out, which is very exciting for us. First of all, same-day surgery was something that wasn't allowed 10 years ago. Your insurance company wouldn't even hear of it. And now it's almost becoming standard of care. The types of implants we use, the stems, which is the part that goes into the humerus, they get shorter and shorter now because they've developed better ways of having the material grow into your bone. And that's great, particularly for young people, because it means that if and when we have to take it out to revise it, there's so much bone left over for us to use for the next style of implant that can still give you a very nice result for the next 10, 15, 20 years. In addition to that, there are lots of different components that go onto the scapular side that can get built up or built down in order to specifically fit a patient's deformity, which was something that we had a very difficult time treating just 10, 15 years ago. There's also like virtual reality and preoperative computer templating, where we have your exact anatomy modeled in the computer so that we can plan the surgery beforehand with patient-specific instruments. So we know where everything is going. We know the sizes. We know the amount of screw threads that are going to be in your socket. It's pretty incredible how we can really just do the surgery before we actually do it in the operating room, so that there are fewer surprises. And then lastly, for total shoulder surgery, there are times where we need to do tendon repairing at the same time. And that is very important for the outcome of the surgery. And even with our soft tissue tendon repair techniques in the setting of total shoulder replacement, those have advanced dramatically just over the past 2 to 3 years with some of our sports medicine style tendon implants and sutures. So it is a good time to be a shoulder replacement candidate if you find yourself in that position. Thank you.
Excellent. Thank you so much, Dr. Muñoz. That was very comprehensive, and we really want to thank the hundreds of participants that are with us tonight, because They are on top of it. They're asking a lot of questions, many of which are going to be covered in our presentation. So hang with us and wait for the Q&A session, because a lot of those questions you already have are going to be answered. So now let's turn it over to introduce Dr. Jaime Carvajal, an orthopedic surgeon and expert in joint reconstruction surgery, currently working as an assistant professor of orthopedic surgery in the Miller School of Medicine, Department of Orthopedics. His clinical focus is hip and knee replacement, and a lot of you are asking about that, robotic assisted surgery, and rapid recovery protocols in joint replacement. Dr. Carvajal has been on the faculty of the University of Miami for the last 7 years and is involved in training national and international surgeons in the field of robotic surgery. Dr. Carvajal, you're very popular tonight, so you're on.
Thank you, Liana. First of all, I want to thank also, UHealth to create this space so we can reach out to our patients in a comfortable way through Zoom. And also, I want to thank the audience for being here and for allowing me to share a little bit about the knowledge of joint replacement and the new technologies that we have. We're currently working on, and that on what is on the horizon for our joint replacement. So part of the discussion between doing a hip or a knee replacement starts with the fact that we have to sit down as a patient and the surgeon to go over all the potential options for treatment, all the questions that the patient have. And for me, one of the main, most important factors is patient communication, like the communication between the physician and the surgeon. So it is not a surgeon telling you what to do or telling you what the best option is for you, but actually making a shared decision between both the patient and the surgeon, knowing what is ahead and what are the options available. So regarding hip and knee replacements, we usually start the visit getting a very general plain radiograph, meaning that we don't need to get an MRI, we don't need to get fancy imaging testing, but we just get a plain MRI with the reason that we want to see the space between the two bones. For example, in this case, what you see on the left side, we see a hip that shows a ball in a socket, and there's plenty of a space between the two bones. So this patient might have pain coming from soft tissues, but not really from arthritis. On the right side, we see the bone touching against the other bone. So at this point, this is a patient that I know has been experiencing a lot of pain, and it is probably likely going to benefit from a joint replacement. Same thing happens with the knee. So basically, we go from the left side, which is the normal knee, to the right side, which is the more arthritic knee. And basically what happens is the lining of the articular surface starts wearing down. And that's what patients call wear and tear arthritis. So what happens is the cartilage starts wearing down to the point that there is no more cushion between the two bones and the femur or the thigh bone and the tibia, the shin bone. So what happens is when the patients walk, then you can see that they are starting to have more pain and more symptoms despite all the treatment options. So when I see a patient with an X-ray looking more like a knee on the left side, I would probably be more conservative. But when the patients go to the right side hand, when there's severe arthritis, then it helps me knowing where the patient stands and what the treatment options for this particular patient is. So multiple options, and we're going to talk about what the American Academy of Orthopedic Surgeon guidelines are. So basically, this is a meeting where all the, a big part of our orthopedic surgeons in the United States go and check all the literature available, all the research that has been done, and create these guidelines for our own knowledge and our own benefit. And then, we go and treat the patients conservatively through these guidelines. And just to give disclosure, so all the patients should start with conservative management first. Most of my patients know that I don't operate on patients that have not tried conservative management. And I think actually the clear indication for surgery is when the patient has actually burned all the bridges, they have tried everything and nothing seems to work. At that point is when joint replacement, becomes a clear option. So a little bit of things that Dr. Muñoz already touched base on. So we start with a few things that we know help on the first stages of arthritis. So you usually prescribe a physical therapy protocol because that will help strengthen the muscles around the joints and protect the joints a little bit. We know by a fact that weight loss has a significant impact on relieving the pain from the joints. Obviously, the heavier the patient is, the more load that joint surface is gonna sustain, and it's gonna be a little bit more painful. So we try to emphasize the importance of weight loss. We have TENS unit, hot and cold therapy, also that decreases the swelling, that we call it modalities, and acupuncture is also an option. There are recent discussions about ablation. So basically, what that means is there are a few nerves around the knee joint that can, carry the pain from the joint and take it to your brain. So basically, there's a treatment option of burning those nerve endings, and that helps with the pain. I usually, so this is a little bit of a controversial matter. Sometimes it helps a lot, sometimes it doesn't. I try to leave this particular treatment option for patients that are not surgical candidates, the guys that are a little bit on the more obese side, that have high risk of infection, as Dr. Muñoz mentioned in the past. So these patients, we can try this as another option for pain control while they get optimized for surgery. There's a lot of questions about orthosis. Obviously, using a cane, a crutch, or a walker can decrease the force that you put through the joint, so definitely is recommended. I am not a good fan of splints or bracing in the knee, or obviously not in the hip, but in the knee, because usually what happens is the brace can decrease your range of motion and decrease your muscular strength, and that actually makes the pain worse. So I usually tell the patients to use a neoprene sleeve, something to actually make your knee feel supported. That is just not enough for pain control, but you don't really need a brace with metal bars or anything around it, because usually if you don't have any issues with ligaments, usually arthritis doesn't get better by that. There is in the past, we used to use some insoles in the shoe to kind of try to convert the alignment of the leg and maybe getting rid of the pressure over that worn compartment, but that doesn't seem to be doing a lot of difference in treatment. So we also start, part of the first line of treatment is oral medications. And as Dr. Muñoz mentioned, usually we try to start with anti-inflammatories, knowing that they have side effects like having gastric issues or renal problems, kidney problems. So usually we have to be paying close attention to the patients taking it frequently, because they can actually be harmful. So we start with anti-inflammatories, and then acetaminophen seems to help as well with pain control. Now, glucosamine and condoitrine, it's a very common question that I get from the patients. There's no clear research data showing that they actually make any difference to the pain or to the quality of the cartilage around. There's a lot of marketing efforts outside the university, with all these new medications that are potentially making your cartilage regrow, and it is not really proven by scientific data. So I tell my patients that after the first line of treatment, which is the anti-inflammatories therapy, physical therapy, weight loss, the next step is the intra-articular injections. And the intra-articular injections consist of steroids, which is what we call cortisone, and hyaluronic acid, which is called, it's just a kind of like a jelly substance. Now, we do treat the patients with injections. Sometimes the injections help a lot. Sometimes they relieve the pain for more than 3 months. Sometimes they don't last as much. So one of the things that I tell the patients is, we can give it a try and see if it helps. If it allows you to do all the physical activities that you want to do, if it improves your quality of life and it lasts a long time, then we can continue doing the injections on a regular basis. Now, knowing that these injections won't make the cartilage regrow, they won't make the space back. So you're still going to have the problem, but at least it's going to help you, controlling the pain and maybe delaying a little bit of the surgery, especially for patients that are super young. So yeah, same thing that Dr. Muñoz mentioned before. Every patient is different, and part of the reason why the visit, the clinic visit is so important is because we have the opportunity to make sure that the patient that is in front of me is a good candidate for surgery if they have failed conservative management. If the patients have, as she mentioned, if they're obese, if the body mass index is higher than 40, if they're smokers, if your diabetes is not well controlled, then you're not going to be probably the best candidate for joint replacement surgery, as the risk of complications is a little bit high. And the last thing you want is having a complication after joint replacement. And for patient outcomes and for successful outcomes, it is very important for the patient to have clear expectations. If you know what you're getting into and you know what you can get from the surgery itself or from the treatment options, then it is better for you because you can understand afterwards. You're not expecting something that is definitely not going to happen. So clear expectation is key, and it is very important for us to share that in the visit as well. So as I started with, first we have to, it's a patient-surgeon decision. It's basically both talking about options, telling you exactly what is out there for you, and you and I deciding if this is the best option for you, depending on the treatment. So as I said, all the surgeries, all these knee and hip replacements are elective. And then basically we have to try conservative management first. Then if that fails, then we can offer joint replacement surgery. So before we move into this, I wanted just to go back and recap and telling you that after we burn all the bridges and we tried conservative management and nothing seems to help, then the next step is joint replacement. Now, when we talk about hip replacement and knee replacement, they're two different things. When we do the hip replacements, we are actually replacing the joint, like Dr. Muñoz mentioned on the shoulder. We do take the ball of the hip out and we put a new artificial ball in, which is a ceramic ball usually. And we put a metallic stem inside the bone to hold it together. Now, with the socket in the pelvis, we also clean the socket and we put an artificial socket made from titanium, and we put a plastic liner, a polyethylene liner inside the cup. So what happens is when you move, the ceramic ball is actually articulating with the plastic liner, and that takes away the pain from the arthritic hip. There's no more bone on bone, there's no more pain, and actually the patients get to recover pretty fast. Now, when we're talking about knee replacements, we're actually not replacing the joint, and that's something that patients get concerned. Am I going to get a big piece of metal in my knee? Is it going to be all changed? And it's not really what happens. What we do is basically we resurface the knee. So we take the arthritic surface and we clean it. We take about 8 millimeters of bone all the way around the femur and the tibia, and then we put a new cap, a metallic cap on it. And in between those two metals, we put a plastic. And that actually takes the pain away because, again, there's no more bone on bone. Your tendons, your ligaments are still yours. We do take the cruciate ligaments, but the other ligaments like the collateral ligaments, your patellar tendon, obviously, and the quad tendon, and your own kneecap, they're still the same. They still stay there. We're just basically resurfacing all the damaged surfaces so you can actually walk and do everything. So, and I'm going to talk in a second about knee replacement itself. It is very important the way we put the implants in, because we're talking about two surgeries that are supposed to last 25 years, maybe 30. So they have to be very precise in the way we do the technique. If the technique is very precise and you put them in the right place, then when the patient walks, the idea is for them to load the plastic evenly in the entire surface so there's no wear. And that's very important, because if your components are a little bit tilted, then you're going to wear down the plastic a little bit more on one side compared to the other. So that shows me on the left side is a knee replacement. You can see the surface of the femur in the top and the metal piece on the bottom, and then there is the plastic in between. Now, one of the things also that is very important is, they have to be placed on the right place as well. They have to be, they have to recreate your own anatomy. So every time you do exercises like biking or swimming or going when you're actually hiking, you might feel that your own knee is behaving well, that is not loose, that is the ligaments are tight. So it's very important to recreate the anatomy. So this is the way we have been doing it since 1970s. We actually use these instruments to do the surface cuts. And as you can see in the top left corner, we can see how we actually shape the femur. the top bone, the thigh bone. So we actually were able to get inside the femur with a guide, with a metallic guide that will tell me how many degrees I'm cutting, and then I put a block, I pin the block in, and then with the saw, kind of like take the surface out. Now on the bottom left, we can see how we cut the tibia. So basically we used to put a rod, a metallic rod down the leg, and with surgeon expertise and their own judgment, we used to align that metal rod with the surface of the shin bone and create a cut that was perpendicular to that surface. And then the idea is to pin a block, and then we go with the saw, and we get the cuts done. Now, if you do a ton of these surgeries, you become really good at it and very reliable, but you can see that there's still a chance for error. Every time it's a judgment, you can really be off 1 or 2 degrees, or you can be off a little bit because it's just looking at a metallic rod. And this didn't change for the last 20 years, I say. And this takes me to the next slide. So basically what we're doing now, and what is actually booming in our practice, is robotics. So what that means is we have a camera, as you can see in the left picture, we have 2 cameras, and we have all the systems to kind of like take a look of your knee. We map the knee. So the way it works is we put 2 pins in the thigh bone and the shin bone, and we put trackers so the computer can know exactly where your leg is in space. Then in surgery, we create with another stylus that has trackers, we can collect the points on the surface of your bone. So on the left side, you can see how we're actually mapping the femur, and on the right side, we are mapping the tibia. And the computer, the robotic arm, is actually recreating that 3D model during surgery. And this is also very important. Some of the systems, you need to get a CT scan before surgery to do this. Some of them don't. And this particular, you don't have to use a CT scan. You actually create a model, a 3D model of your knee in surgery. So that tells me, so it's going to give me a lot of information in surgery. Before I move to that point, we do check range of motion before with your arthritic knee. We check how much motion you have in the left side. And in the right side, we can actually check how your ligaments are tight. Sometimes you have on one side, the ligaments too tight, on the other side, the ligaments are too loose. And that also tells me how your knee is behaving. So this is a slide. This is the screen that I get when I did all the mapping, when I checked all the ligaments. This is the size. This is the time with the robotic arm when they looked at your knee and they checked how your knee was behaving. This is how the implants are going to look. So basically, what they say, all right, this is almost like a customized joint replacement. Tell me exactly the size of the implant that better fits the anatomy, and that is going to cover all the areas of the bone. And it also let me change in order to make sure that your ligaments are tight in both sides. And we were talking about the importance of having the implants placed in the right side, the right way. So this allows me to definitely recreate what you had in your knee to make it work perfectly. Go ahead, next slide. So after we did this planning, and I'm happy with the way the implants look in the 3D model, then the robotic arm has this smart burr. So basically what it does is actually cut the bone that needs to be taken away. Only takes the bone that needs to go away. So it's smart. Every time I get into the bone, the burr comes out and actually takes the bone out. So it's very precise in both the thigh bone and the shin bone. And what allows me to do is actually put the cuts perfectly. When I do check when I finish the cuts to make sure that I did it in the right place. And the variability is about 1 degree and less than 1 millimeter. So it's very, very precise and allows me to get the implants placed in a really, really good position. And so at the end, not only I put the implants in the right place, but also I can check after I put the implants in, what the range of motion of the patient is compared to what it was before. And also making sure that the ligaments are in the right place. They're nice and tight in both sides evenly. So when the patient is walking, doing all these activities, it will feel that the knee is more like their own. It will feel that the knee is behaving how it's supposed to be. So besides robotics and besides the precision that robotics give us in joint replacement, everything now is about data. And we want to hear about our patients. We want to make sure that the patients are doing right, they're doing well, the therapy is going well. So we started getting into wearable devices. And what that means is we actually can put trackers or sensors in your knee, and it gives us information about your recovery. So basically, the patients stick those two trackers in the knee, and it shows me how much range of motion the patient is having. And with time, it allows me to see how the patient is actually improving with therapy. It has an application for iPhone or for a smart device to the patient, and also is connected to the surgeon. So that allows us to see which patients are lagging behind a little bit with range of motion. It gives us an opportunity to track recovery much better. Now, even better, now there are implants that are called smart implants. So now, one company of knee replacement actually have a tracker, like an inside of the replacement, a sensor that would allow me to see how many steps the patient is doing, how many, what is the stride length, if the distance that the patient are able to walk, the speed, and the range of motion. So it's all about data. A little bit of patients a little bit hesitant because they think they're tracking their location, and it's not true. But obviously, people sometimes feel a little bit on the edge for this type of technology. I do think that the more we know of our patients and the closer we can follow them, the easier it is for us to intervene. For example, patients can have stiffness after surgery. If we know about this stiffness early in the process, then we can probably do something about it rather than just waiting and then seeing them in the clinic. So I think this is a very important aspect of joint replacement, tracking them closely and making sure that they get treated if they need to. And then this is what is coming out. I think Dr. Muñoz mentioned something about it as well. So, and this is going to be coming up pretty soon. And not only for training of our residents and teaching them how to do the surgeries in a virtual reality type of environment, but also during surgery. So I will think that in the future, what we're going to look like, we're going to have all these goggles, and we can actually see while we're looking at the patient in the surgery, we can see numbers and we can see positioning, and we can make sure that what we're doing is actually in the right way. So this is coming up already. There are a lot of companies working on this. Research is heavy on this, and I think this is going to be the future. Just going and manipulating all the data that we can get inside of our own surgical field, so we can make sure that the replacements are performed perfectly and very precisely. Thank you so much for your time.
Thank you so much, Dr. Carvajal. And now it's perfect timing to begin our question and answer session. You remember how to use the Q&A button in your Zoom toolbar. I see that many of you have found it, and many of you are engaging with our experts. I think both of our expert providers did answer this question very well in their presentations, but it seems to be that pain control is a hot button. So in a nutshell, both of our experts, can you share recommendations for patients who are not good candidates for surgery, but who want to manage joint pain without narcotics? In a nutshell, tell us.
So I can take that. The mainstay of my conservative pain control treatment are anti-inflammatory medications. And so over-the-counter options would be things like Aleve, Motrin. But we have multiple options for prescription styles of those medications. And the nice thing about the prescription styles is that typically they'll last longer and they're easier to tolerate on the stomach, because non-steroidal anti-inflammatories are notorious for causing acid reflux and heartburn. So when we use them in a prescription format, you often have to take fewer of them. They're stronger, so they work better. And some of them have a much better acid profile.
And Dr. Carvajal, would you just like to say a few words on that as well?
No, I agree 100%. I think narcotics are great for acute pain right after surgery, but the longer you take them, you become hypersensitive to pain. So actually, I try to get rid of narcotics as soon as we can, because it becomes a cycle, and that's when patients get addicted. So definitely, first line for treatment is always anti-inflammatories, Tylenol, or other medications, rather than just going with oxycodone or Percocet, because they can become they can be highly addictive.
Excellent. But obviously pain is something that is so difficult to live with that people are, get desperate. So let's take our next question, which is also something we've been bombarded with in the Q&A chat box, is how long do today's knee replacements typically last? And if a person's life expectancy is much longer, is it better to wait so they don't have to face surgery and perhaps rehab in their 80s and 90s?
That is a great question. It usually, it depends on the age and the activity level. I usually tell the patients to try to wait as long as possible. With the advances in surgical techniques, in materials, and obviously with robotics, I think the more precise you put the implants, the longer they're going to last. So, we used to say tell the patients about 15 years will be a good timing. I think now we're going into the 20, 25 years. Just because, again, the implants are better made and the techniques have improved. Obviously, that depends on the patient activity. If the patient is very active and they're going to go and jump or run in that knee, they're not going to last as long. Either way, my main recommendation is try to wait as long as you can, especially if you're younger. If you're under 50, that will definitely try to wait as long as you can.
And Dr. Muñoz, same for you. What's the lifespan of a shoulder?
Yeah, so for patients over the age of 65, total shoulder replacements can pretty reliably last 15 to 20 years, which it's a little bit of a morbid way to think, but the average lifespan for an American is somewhere in your 70s. Most of us, if we stay healthy, are expecting to live much longer than that. So just for comparison, if you were going to get a joint replacement at age 69 or 71 or 74, that could very realistically last you the rest of your life. I have many patients. I actually spend half of my week treating patients at the Miami VA. And so many of these patients end up with arthritis very, very early because of their military service, which is really very challenging thing to deal with. So I have quite a few patients in my practice, especially on that side of the street, that get joint replacements in their 50s. And we have a very long preoperative discussion about how I am expecting that they are going to need to have a revision at some point, most likely in their 70s. But the other caveat to that is that we typically end up being more active, more aggressive with what we're doing as we are younger. So sometimes as you're growing older appropriately with your joint replacement, if that makes sense. So even though the joint replacement is expected to last 15, 20 years, for example, probably not going to be doing the same exact things at age 88 as you were at age 68 when you got it in the first place. So there's a very good chance that you'll still live with it to 102, which is how old my grandmother is right now.
God bless. Yeah. So in other words, you won't be on the squash court, but you'll probably be on the golf course. So that's okay.
Right.
So now here's the next question. For people who are candidates for double knee replacements, what are the pros and cons of replacing both knees at the same time, Dr. Carvajal?
So yeah, most of my patients ask, they want to try to minimize the time they're off work and they want to get things done quickly. I do tell them that the risk of complications is a little higher, and unless both knees are really bad and one cannot recover with the other one, then you're not a candidate for a bilateral knee replacement or both knees at the same time. The longer you stay in the operating room, the more blood loss you have, the more risk of infection, the more risk of requiring a blood transfusion, and the more risk of having issues with your therapy. I mean, having a replacement is still tough, and you get to do a lot of the therapy. So I like the patients to concentrate in one, which is the most painful one first, and then we move to the other one and get it done, usually within 6 weeks to 3 months, when they have fully recovered from the previous knee replacement. I think doing both can happen, they can be done, but the risk is too high. So I wouldn't take it unless definitely there's no other option for your knees.
Yeah, and not to mention the difficulty with recovery with both being affected.
Right.
Okay, here's another question that also came in advance. I've had 2 hip replacements, one 10 years ago, the other 7 years. My concern is wear and tear on the replacement ball. What happens if it deteriorates over time? Does it need to be replaced? How traumatic is that?
So usually the wear is not in the ball, it's actually more in the plastic liner. So I'm expecting to notice from x-rays that the position of the ball inside the socket is going to start trending up. So that's how I can tell that the plastic is wearing down. So usually I follow patients after surgery, as Dr. Muñoz said, at a year, and then at 2 years, and then every 3 to 5 years with x-rays, just to make sure that we can see if the prosthesis is wearing down. And if we can see it because the ball again starts wearing through the plastic and it starts to move up. It's not very traumatic. Sometimes it doesn't even hurt, but you can see the bones around the metal start weakening just because of the plastic debris going around the joint. So that's why very important for the patients to follow and get, x-rays, follow up with x-rays to make sure that it's not happening. Because at some point, if that is noted and the bone is weakening, sometimes the components can get loose and we can go back in and have to revise them. We have to put new implants in with a new plastic liner. And it is a more complex surgery. But it is important to have close follow-up with your surgeon.
Let's keep moving through these as fast as we can because we have a lot of on our plate. Dr. Muñoz, this is for you. Are plasma stem cells good for joint pain? We keep getting a lot of questions on this. And does taking collagen peptides really help to maintain joints and prevent degeneration?
Yeah. So I answer this question every day in the sports medicine clinic. And I hate the answer that I have to it because we just don't know. We don't have great data for any injection therapy other than cortisone. So the injectable options, the most tried and true one is cortisone, which is essentially a local steroid, which works as an anti-inflammatory agent. And there is data that suggests that that can reduce inflammation and therefore help with pain control. It is not a permanent solution. There are some theoretical side effects that it can degenerate some soft tissues. So that can be a problem for tendons in the area, depending on what the situation is. And prolonged use can actually deposit some, it can leave some deposits in a joint space. So if you get them repeatedly over and over and over again, particularly if they're not working or they're not lasting long enough, then it just becomes something that is no longer worth it. And it's probably worth discussing the next line of options. But cortisone is the only thing that's been actually scientifically shown to reduce inflammation and relieve pain for periods of time. The other injectable options are anything from hyaluronic acid, which is essentially a type of protein that lives in the joint fluid anyways. It goes by names like Orthovisc or Synvisc, if those are things that your doctor has talked to you about. They're lubricating gels that they are very low risk. They are sometimes covered by insurance in the knee. They are never covered by insurance in the shoulder because again, the data on them is very gray. So, and what I mean by that is that there's probably 50% of data out there that shows that it does something beneficial for symptom control. It does not cure disease. It does not regrow cartilage. And there's 50% of studies that show that it does nothing for symptoms. And we already know it doesn't cure disease. So when you're in a situation like that, an insurance company is never going to cover that modality. So it would be something that you would then have to pay out of pocket for that medication. And then you would bring the medication typically to the visit, or sometimes the medication can be delivered to the physician's office and then injected at that point. The same thing goes for PRP and stem cells, unfortunately. The data is gray. The data doesn't unanimously show that it doesn't work. It's just that half of it shows that it does something for symptoms, not for cure, and half of it shows that it doesn't. So again, insurance companies will not cover something like that. So for platelet-rich plasma, that would be where you get a blood draw at the physician's office. They spin the blood down to the watery component of the blood that has a lot of theoretical healing factors. And that's what gets injected back into the joint space. Stem cells, typically more expensive because that's something that's been manufactured or manipulated and then it's sold by a company. So obviously it's way more expensive than you taking your own biologic material and re-injecting it. So what I tell my patients is that I would always first recommend cortisone to see if it helps with symptoms, because that's what we know more reliably will help you with your symptoms. And it's also very much most likely going to be covered by your insurance. The others, it depends on whether you can afford it, quite literally, because some of the options are quite expensive. If you can't afford it, then it's a no-brainer. And I would tell you not to lose a wink of sleep about it, because we don't have data to suggest that it is a slam dunk anyways.
But Dr. Muñoz, let me ask you this. Can you overdo it with cortisone, with steroid shots?
Absolutely. So again, so if you repeatedly use cortisone, then you can theoretically wear out tendon tissue and you can leave some nasty deposits in a joint space. So for my patients, if a cortisone injection has helped for months at a time, so if somebody needs 1, 2, maybe on the rare instance, 3 cortisone injections in a calendar year, and they have medical problems that make it so that joint replacement is just never going to be safe, I think that's a fair trade-off. If I have a joint replacement patient that's tried one cortisone injection, it's done nothing for them, they are healthy and otherwise a fantastic candidate for joint replacement, don't inject anymore. You need to talk about whether a joint replacement is the way to go at that point. So you can already tell in the way I'm answering this, it's a very personalized discussion. There is definitely a role for some patients for cortisone, not forever, not every week, not every month. And the other injectables, even more personal, because it depends on whether you can afford it, how you feel about something that, doesn't have great data to suggest that it's going to help you. But that's the truth of it.
All right, I'm going to grab some of these questions from our chat. Here's one on, are there certain requirements for robotic knee replacement versus conventional surgery, Dr. Carvajal, and which advanced technologies are in use now at UHealth?
Right. So actually, robotics help for every single knee replacement. I mean, there's no particular candidates. Actually, the more you use it, the better. The more you know how to use it, and the more precise you're going with your surgeries. UHealth has actually two types of robotic systems. It's very unique actually for South Florida to have both of them on the same place, and we do have them. One is the Mako with the Striker, and one is the Corey with the Smith and Nephew. So they're both very similar robotic arms, and they actually can perform the cuts as I mentioned. But there's no particular candidate, I will say. Every patient that is a candidate for knee replacement is a candidate for robotic knee replacement. And actually, if I were going to have my knee replaced, I would probably go to a place that has robotics. Just because, again, we're leaving a little bit to chance that your component might be a little tilted. With the robotics, that chance is off. I mean, you're always making the cuts very precisely. So I think all the patients will benefit from it.
And we're happy that we have it at UHealth, obviously.
Oh, yes.
Let's try and get this one real quick too. Can a knee replacement be done, and I think you did it in your presentation a little, on a knee that is fused due to arthritis?
Usually there's times where the arthritis is so bad that there's basically no motion left. And in those patients, we can actually do a knee replacement. Now, it is very likely that all the tissues that are around it were so stiff for such a long time that stiffness could be a problem after surgery. So patients' range of motion after surgery, has to do a lot with how much motion the patient had before surgery. So if you're very stiff before, it's probably going to likely that you're going to be stiff as well, but without pain, because there won't be arthritis.
Okay, how about this one? What are the risks of having no pain perception after ablation and continue using or overusing the joint?
So yes, so basically, when we do the ablations, they don't take the pain completely out. So patients are concerned, well, what about if I'm not feeling the knee? Can I damage it more? Not really, because the pain, it's a little bit turned down a little bit, but it's still you can have sensation intact. So you can actually know when you're harming your joint.
I think the final question that we'd like to get in, and this is one that it's a risk of any surgery, and that is the likelihood of a patient experiencing infection following joint replacement surgery at UHealth. How to address it for those already battling joint infection, perhaps even from a previous surgery.
So for the shoulder, in general, for all comers, the risk of infection for anatomic total shoulder replacement is around 1%. For reverse total shoulder replacement, it's around 5%. That has to do a little bit with the technique of surgery, how long the surgery lasts, how big the surgical field is, and technical things of that nature. A lot of it also has to do with the initial reasons why somebody's having a reverse total shoulder replacement versus anatomic. I think the important thing to understand is that there are preoperative, intraoperative, and postoperative things that can increase your risk for infection. And so really, there is nothing that will make it zero. If there were, we'd all be doing it. But the idea is that it needs to be a conversation with your surgeon about how for you specifically, you are going to get that risk as low as possible. And some of the examples we talked about preoperatively, diabetes needs to be controlled. Hemoglobin A1C needs to be below 7.5, the lower the better. Smoking needs to stop really, or get as close to stopping as possible. And even then, it needs a discussion about how your risk is still elevated. One cigarette is one cigarette too many before a joint replacement, in my opinion. And there are many, many resources we have to help people quit, which I spend a lot of time discussing with my patients. Intraoperatively, I won't bore you, but there is a whole host of technical things that we do in the operating room to reduce that risk in terms of the way we implant, the way we dress ourselves, the way we clean ourselves, the way we clean you, the way that we bathe your wound, the type of suture we use to close it, the type of dressings we put on afterwards, when we tell you to take the dressings down. And then post-operatively, again, making sure you're in a good environment for recovery. So, having a helping hand, somebody that can help you bathe, somebody that can help make sure that, you aren't doing too much too soon to make your wound break down and open up. I could go on, but.
Yeah. Well, I think in conclusion, I'd like to hear just a very brief statement from each of you. We're fortunate that we're in the 21st century and that the technical and medical advances have gotten us to the point where we can have a Mako shark robot do your surgery and all these things that you all talked about. Fascinating tonight. So we could take a lot of the fear out of this before. Yes, don't jump into surgery if you don't need it, if you're not a candidate, but please give us just a conclusion statement from each of you.
Are you letting me go first?
Yes, of course. What a gentleman, Dr. Muñoz.
I knew he would. He's a friend of mine. I knew he was going to do that. But actually, Ileana, I think you hit the nail on the head. So, it's a little ironic, but we're surgeons, but we also love to keep people out of the operating room. So if you are not an appropriate candidate for joint replacement, if you don't have end-stage arthritis and you don't have pain and limited range of motion, this is probably not going to be a great solution yet. If you are that patient, then come in and talk to us about it, because this is, like I said earlier, it's the best time that there has ever been to be a patient that needs a joint replacement. So.
Yeah, I think so too. Dr. Carvajal, your concluding words, please.
I agree 100%. And, not only, try conservative management first. If that fails, there's a good option of going into joint replacement. And this is a great time because, again, technology is playing a big role, not only in implant materials, but also in the techniques to make sure that you get almost like a perfect joint replacement. So don't be afraid. And I think there's a lot of technology right now and in the development that are going to be amazing in the future. So it's a very exciting time to be on.
Yeah. Thank you, Dr. Carvajal and Dr. Muñoz, for lending us your expertise and for taking a little bit of the fear out of this. Thank God that we have UHealth in our backyard where people can go for this kind of treatments. But our program has ended. So we want to thank our expert panelists. Bravo, you did an incredible, excellent presentation. Also to our interactive audience, 200 of you engaged throughout all of it. And we'd like to thank you because here at the University of Miami Health System, we appreciate you. We're here to care for you. And so many of you had a lot of detailed questions, and that's why we ran over a little bit, but please visit umiamihealth.org or call 305-243-3000 to learn more, to make an appointment virtually, in person, whatever you need, whatever you're comfortable with our experts. And please complete the survey at the end to provide feedback on this talk and give us other topics. Dr. Carvajal, Dr. Muñoz, good night. Good night to our team. To all of you, have a great night. And please, please stay safe out there.
Good night. Thank you so much.